Happy Thursday, and wonderful to see all of your shining faces. Today is brought to you by the Smiley Mug. I don't know how everyone else's world is going, but I figure I'm going to just add a little extra cheer. Super excited to be with everyone today, and we will start with welcome and public comment. So we will go around the screen and sort of toss it to people, and hopefully we'll catch everyone. And then we'll go to public comment after that. And the first person that I'd like to introduce is that we have our incoming executive director, Carmen Madrid, who has joined us this afternoon. And I just want to give her the grace of, we know that she won't be able to stay the entire meeting. She's here just to kind of get a feel for the meetings and have a chance to see everyone's faces. And so Carmen, just wanted to turn it to you if you just wanted to say hello, and then if you wanted to pass the ball maybe to Donna, and we can take it from there.
Great. Thank you for having me here. I'm just in the background and wanted to get a sense of the board meeting, and I was invited and found some space before I head out to Central Oregon. So very excited about the role. Everyone's been amazing in terms of welcoming me. So thank you. See, I'm already out of voice here. So
we've choked you up already.
Right.
So I realize that you're actually sitting between boxes. So that's,
right. I actually
that's okay.
am. Actually, if you want to see my living room, like there's my boxes right there. So,
oh my
well, I guess she's really coming. Yes.
Right. Yeah, and I got rid of so much stuff. So
that wasn't just staged, but no, thank you so much for joining us. I know your time is short today, but I hope you'll actually be able to take a breather from packing. So good afternoon, everybody. My name is Donna Mills, and I am currently serving as the executive director for the Central Oregon Health Council, and my pronouns are she, her, and hers. And I will toss it to Brad.
Hi, everybody. Brad Porterfield, consumer representative, the chair of the CAC, and also the director at the Latino Community Association.
We just had an amazing event. Congratulations. Do you want to pass the ball on to someone, Brad?
Sure. Are we doing, does it matter who?
Nope.
Anybody?
Anyone.
How about Ralph? Is that your name, Ralph?
Mike.
That's not your name, is it? Yeah, that happened to me once before.
It's okay. And he's on mute. Someone had to do it. So I'm sure what you're saying is brilliant.
There you go. I got it off. That's what happened last time. I had a disconnect with the sound, and your wonderful staff figured it out for me, so you can actually hear me. I felt bad last time because I got such a razzing from everybody, and I had some really good comments back. But I'll not do that. I appreciate being able to get on and seeing everybody, and some of you I don't know. I served on the council back in the day before I retired from Advantage, and I've been helping Dr. Higbee and a couple of providers, and they wanted me to start participating in some meetings so they could see what was going on. So it's nice to be on. Nice to see all your smiling faces. Thank you.
Excellent. And Mike, do you want to hand it to someone? How about Michaela?
Michaela, there you go.
Good afternoon, everyone. I am Michaela Arsenault. I'm one of the project managers at the Central Oregon Health Council, and my pronouns are she, her, and hers. And I'll pass it on to Linda Johnson.
Hi, Linda Johnson, community representative on the Health Council, vice chair and chair of governance committee, and my pronouns are she, her, and hers.
And would you like to pass it to Divya, maybe?
Yes, Divya.
Hi, Divya Sharma, she, her pronouns. I am Chief Medical Officers for Central Oregon IPA and La Pine Community Health Center. And let's go with Rebecca.
Thank you. I'm Rebecca Berry, she, her, hers, and I'm the Grants and Metrics Manager here at the Central Oregon Health Council. I'm going to pass it to my newest brainstorm colleague, Connor.
Hi, everyone. My name is Connor Carlson. I'm a CAC consumer rep, work at the Family Resource Center, and I was invited today to tell a patient story. So look forward to sharing that later. And I'll pass it to Patty Adair.
Hi, good afternoon, everyone. I'm actually sitting in St. Charles My
Oh,
husband's having a procedure, so I know how appropriate that I would be on the health council call. So thank you. And Tammy, can you pick somebody? Because my phone is kind of not working well.
I would be happy to. And look at your commitment. Gold star for Patty today. And so I'm going to pass it and do take care of your husband as you need to. So drop off whenever you need. I'm going to pass it on for you to Megan.
Good afternoon, Megan. Pronouns are she, her, and hers, and I'm with Mosaic Medical and Safety Net Clinics.
Excellent.
I will pat Leslie. You haven't gone, have you?
I have not. Leslie Neugebauer, Senior Director of Medicaid Governance at Pacific Source. Camille?
Hi, I'm Camille Smith. I'm the admin at Central Oregon Health Council. It's good to see you all here today, and I'm going to throw it over to Tricia.
Hello, everyone. Tricia Wilder, she, her, and hers pronouns, and I'm the director for Central Oregon for the Coordinated Care Organization for Pacific Source. And how about you, Kat?
Hi, Kat Mastrangelo, Volunteers in Medicine Executive Director, member of the Ops Council, as well as the DEI Committee. And I will pass it on to Renee.
Hi everyone, Renee Worth. I am a project manager with the Central Oregon Health Council. My pronouns are she, her, and hers, and I'll pass it to Gwen.
Hi, Gwen Jones, she, her, hers, also project manager, and I will pass it to Rebecca Donnell.
Hi, good afternoon, everyone. Rebecca Donnell, she, her pronouns, and I'm a innovator agent in the External Relations Division of Oregon Health Authority. And I support the Pacific Source CCOs in Central Oregon, Marion and Polk counties, and in the Columbia Gorge region. And I support the CACs in those regions as well.
Excellent. And how about I pass it to Justin for you?
Hi, everyone. Justin Civil. I'm the Chief Operating Officer for Summit Health. And I don't know who hasn't went yet, so.
How about Wendy Jackson?
Thank you.
You bet.
Hi, everybody. I'm Wendy Jackson, COO at Central Oregon Pediatric Associates. I feel like I don't know who's left either.
It's okay. How about Kristen, Kristen, who I always want to call Kirsten. And
damn, you got it today. Kristen Tobias. I use she, her pronouns, and I am the Central Oregon Community Health Coordinator with Pacific Source. I might know who's been. Let's see.
We have Rick and Iman and Gary.
Iman, you're already off mute.
I am. Thank you. Hi, everyone. I'm Iman Nazari Simmons, and I serve as St. Charles Chief Operating Officer for the system. And who was it, Rick? Who's left?
Sure. I'm Rick Chlevin, LCSW. I'm the behavioral health seat on the council, and I'm the CEO of Best Care Treatment Services. And Gary, I think you're left.
Yeah, I think I'm last. I'm Gary Allen. I'm Vice President of Clinical Services at Advantage Dental. And I apologize, I'm having trouble with my camera. So at the end of these introductions, I'm going to drop off and then try to come back in and hope my camera works. So see you in a minute.
Excellent, Gary. We look forward to it. And I'm Tammy Bainey. I'll be your tour guide today for the meeting, and super excited to have everyone with us. Do we have any public comment as we get started? Okay, seeing the crowd go wild, we will go ahead and move on to the action items for today, which is the consent agenda and the items of the March board meeting minutes. We have the financials from February, and we also have the really important work of ratifying the new executive director selection, and that is Carmen. And so is there any item that anyone would like to take off the consent agenda? And if not, I welcome a motion of approval or as you wish.
I move adoption of all of the above, the consent agenda and the approval of Carmen as our incoming executive director.
Wonderful. And a second?
Second.
Okay, any further discussion? All right, how about anyone opposed? Excellent. Well, again, welcome, Carmen. And thank you so much, everyone, for that. So we will move right into the patient story. And I loved that you, Rebecca, how you introduced Connor. Connor and I had an opportunity to strategize all things of the world. And I think with an extra maybe half hour, we probably could have solved world peace. So super excited to have you with us today, Connor, and thank you for your commitment and time. So I'll just go ahead and turn the meeting over to you.
All right. Well, thank you. I definitely need to tamp down the expectations here, Tammy. So, but I appreciate the kind words. So thank you. My name's Connor Carlson. I grew up in Bend, but moved away in 2008 to further my education, and then worked on the East Coast and came back at the end of 2019. So that's where I'll pick up my story. I'm going to read from a PDF. So if anyone raises their hand, I apologize. It's going to be on my screen. When I moved back to Oregon in late 2019, I needed to find a primary care provider. I was referred to one who had some specific experience in areas that I needed or was looking for. And that PCP was in Clinic A, about a little over 30 miles from where I live. But I was willing to make that drive for the care I needed. The PCP was great, but towards the end of 21, they abruptly quit or retired. Not exactly sure what happened. And we were informed, the patients were informed via a letter from that clinic saying they were no longer seeing patients immediately. And I think this was in October, November of last year. Clinic A assigned me a PCP within their clinic, so my care could continue, which was nice. But shortly thereafter, I was notified by Pacific Source via a letter that they had assigned me a new PC within that same clinic, although it was a different PCP, primary care physician, from what Clinic A assigned me. I was notified by Pacific Source via letter, and I called to inquire about the new provider. I told the rep that I was still looking for a PCP and that which I did find one at Clinic B, who I have yet to see. I see them in June, but they would meet my needs a little bit better than what PCP was assigned to me. And the Pacific Source rep said that that was fine, but that I was only allowed to change PCPs, I think twice in a year. But I'm not positive on that. Since Pacific Source assigned me a different primary care provider from what Clinic A assigned me, I had to reschedule my appointment so the primary care provider would be able to see me and get reimbursed, as my understanding is that a primary care provider must be linked to my account or they won't be reimbursed for my care that they provide. But I might be misunderstanding that. Having to reschedule wasn't a big deal. And while I appreciate Pacific Source being proactive, I would have liked some communication when it came to this decision, or Pacific Source offering to help me find a primary care physician that would meet my needs and care. And I guess just to summarize, healthcare is personal. While we try as a member of the CAC and Central Oregon Health Committee, we try to be as efficient and cost effective as possible, especially when we are dealing with a large population and consumer base. We should do our best to remember that one size does not fit all, but it can fit most. We should try to be flexible and understanding of individuals' needs up to a point and help guide them through this healthcare maze, as it can be daunting for many. I don't know how realistic it is to reach out via a call or email in a situation like mine before making a decision. But I think a little conversation between parties can help ease the transition and uncertainty of change, such as mine. And so that's the end of my consumer story.
Connor, thank you so much. First of all, for sharing a personal story with us. And second, for making time to, and your commitment with the CAC. think you raise a really important point, and you mentioned that our care is personal. And in that, I also hear that trust with your provider too is a really important piece of that connection as to whether people might go in and actually seek care or not. And so is there anyone who'd like to maybe comment on Connor's statements, or is there anything that comes to mind for anyone? I know it certainly resonates with me and is an important piece to the puzzle as we go forward in trying to build a system that works to the best of our ability.
I think, Tammy, can I piggyback on what you said? I think it's also trust in your insurance company as well, knowing that they're a partner with you in your care. So it's not just the doctors, but I think it's the whole support system.
Mm-hmm. Excellent point.
Oh, sorry.
Oh, no, go right ahead.
This is Kristen with Pacific Source, and I did reach out to our customer service manager, and he did assure me that our members are able to change their PCP as many times as they would like each year. So if you're getting different information, please definitely let us know, because that is incorrect. You are able to change your PCP. And I also just wanted to assure you as well, like, let's say you had a PCP just at St. Charles and another provider in that clinic saw you, that's okay.
Okay.
Yeah.
Kristen, thank you for that. I think it also, I know for our own customer care, when we hear something that maybe isn't necessarily as we are hoping it to be communicated to the public, and we hear that on the end of that phone cord, the old can with the string, sometimes isn't exactly what we're hoping to convey. Statements and stories that are coming forward, such as what Connor's presented us with today, helps us to go back and make sure that we are clearly communicating that information to the public as well, and so that we can alleviate those concerns. So I think it's really beneficial. Okay, well, Connor, thank you. Please feel free to stay with us. Thank you also for your work at the Family Resource Center. And we will go forward with the next piece on our agenda, which is governance, and that's the Board Strategic Plan Survey. And I'm going to turn it over to Gwen.
Hi, everyone. So this is just a quick update regarding your mid-cycle strategic plan review. So if you recall, you were provided with an opportunity via email and survey to review your strategies and focus from your strategic plan. 12 board members completed the initial survey, and your reflections are going to be shared with Carmen as she transitions into the executive director role. And next steps will be identified and shared with you at a future date. So stay tuned, more to come. And thank you for giving feedback. There were definitely themes will be exciting to share and explore as a board.
Excellent. I certainly know that'll help Carmen too get a feel for where her board is at, which will be a great revelation. I'm not sure if our next presenter, Carolyn, is with us quite yet. And so I wonder if it might make sense for our team, the Health Council team, maybe to go first, and we sort of mix up the next agenda item. Would that work? I'm seeing some heads nod. Okay. So let me tee this up a tad. The purpose of this next agenda item is continuing forward with the discussion of what's happening in the community right now around housing, some learning for us, and primarily around, although today's example of part of the concerns that are being raised in the community is not necessarily on the crisis end of our current unhoused situation that we have in the region. But it is an important factor into other crises that are coming. It's almost like just a flower that you don't want to continue to bloom. It's continuing to just sort of grow in terms of the housing issues. So this is an opportunity for our board to listen and learn, maybe most importantly, to reflect upon what our role is or is not in this particular public health crisis. And so today we will hear from Carolyn with OSU Cascades. We'll hear from our own team about the investments that we are making currently. And then I am going to encourage us to be thinking about next steps. There are some gaps in areas such as regional planning. There are some transitions of organizations that are currently happening as well. And so just wanting to make sure that we as a board have an opportunity to feel informed about what's going on in the community and have a chance to decide together if this is something that we want to lean into maybe a little bit differently as a board of directors with the Health Council and this particular issue in our region. I would also draw to our attention, there is, while I'm hoping that maybe Carolyn can join us here in just a moment, but there is there have been a couple of information summits, if you will, around the investments of CCOs in terms of supportive services, supportive housing, unhoused, shelter, et cetera, all across the spectrum. And there is another one that is called Partnering to Provide I'm sorry, maybe this one was the one. Oh no, this is June 2nd. Partnering to provide supportive housing services and introduction of CCOs to permanent supportive housing and beyond. And so that is happening on June 2nd. We can kick that information out as well. But there is alignment starting to happen between Oregon Housing and Community Services, some of the other state agencies, coordinated care organizations, and some creative strategic ways to address needs in communities. So that's what I'm hoping to tee us up for. And I think I'll go ahead with that and turn it over to our team. So Donna, I'll turn it over to you first. And then when Carolyn joins us, we'll dive in there.
Oh, sure. There she is, right on cue.
Oh my goodness. Okay, well, cue up Carolyn. Let me just go ahead and start with, although I think she just dropped off my screen. I don't quite see her. I think we lost her.
She was there. And do you want to give a moment, or there she is again? Hi, Carolyn.
I think she's trying to connect. There we are. Hi, Carolyn. This is Tammy. Can you see us?
Hi, I can, and I can hear you. Sorry, I got on, then I got kicked off. So, such is the life of Zoom. I teach on Zoom all the time, so I'm used to this.
Okay, not a worry. Well, I want to just set the table for you so that since you just jumped on. So I've shared with the board that there are a number of efforts that are happening in the community, and that we are going to hear about one of the challenges that is coming, that you are experiencing and that we are experiencing as a region in terms of the housing crisis. And we are putting all of this into context to be able to, in the June timeframe, ask our board, what involvement do we want to be having? Are we involved as we want to be today? Do we want to be involved further in the future? Do we need more information? Where is it that our board would like to take this conversation? So after you present, Carolyn, we will have our team talk about the investments that we're currently meeting, or that we're currently investing in, and then I'll kind of tie it back together. Does that give you enough context? Would you like to go ahead and dive in?
Amy, could I introduce Carolyn?
Let me ask one question, Linda. Let me ask one question. Do you want me to then end and get off when I finish my part as you go back into your meeting?
Oh, goodness. You're welcome to stay as long as you'd like.
Okay. All right. Thank you.
Of course.
Well, great. I'll do just a real brief bio on Carolyn. Dr. Carolyn Platt's a senior faculty member in the College of Education at OSU Cascades. She's the program lead of the Masters of Arts in Teaching degree and licensure program, and has worked with the emerging and licensed teachers for over 15 years here in Central Oregon. She also serves on statewide education, legislative, and policy task forces. Carolyn was elected to the Ben Lapine School Board from 2001 to 2008, serving 2 terms in leadership positions as chair and vice chair. And she's passionate about not only education, but youth in our community and our community's economy. So it's my pleasure to introduce Carolyn.
Thank you, Linda. I'm going to pull up some slides that I have to support what I'm saying today. So give me a minute to get my screen shared with you. Can you all see my screen now? See the
Yes.
slides? Okay, so I've prepared some notes because I wanted to stay within your time frame, which is impressively on time. Wow, I got on 4 minutes early and you were waiting for me. Sorry. Thank you, Linda, and thanks to each of you for inviting me to speak today about a disturbing trend that is beginning to significantly impact our Central Oregon families, our businesses who employ school graduates, and the community's economic health. And that is the inability to attract and retain teachers, administrators, and educator paraprofessionals to our schools due to the lack of affordable and available housing for mid-class professionals whose jobs cannot be outsourced. This concern is echoed in conversations I have had with other professionals in the medical and emergency services field. For the first time in my career as an educator of teachers, I am being told by a large number of our teacher candidates who will be licensed in June that they are not even going to apply to teaching positions in Central Oregon because they can no longer afford to live here. Last week, I surveyed our Masters of Arts in Teaching, our graduate student program, MAT students, who are in the midst of applying for teaching positions. And 11 of the 24 I surveyed said they are looking elsewhere due to the impossibility of finding affordable housing. My slides today provide some of the stories behind the statistics and come from OSU Cascades undergraduate and graduate teacher education majors and from alumni who are teaching in Central Oregon school districts. We work with 6 of our Central Oregon school districts. This past Monday, Central Oregon Districts hosted its annual educator job fair, which traditionally has been packed with aspiring educators. Instead of back-to-back all-day, 20-minute nonstop interviews that had typically been the norm, the attending administrators told me the venue was almost empty and that they averaged as few as 3 interviews that day each. Our expected MAT cohort for entrance this June has dropped from the typical years. We have 45 to 60 entering teacher candidates to be graduated the next June. It is dropping down to a cohort of approximately 20, with several of our admitted applicants citing that they cannot find rental housing and therefore must withdraw. The teacher candidates in our undergraduate and graduate programs tend to be mid-career changers and with partners and families for whom a dormitory room or taking on multiple roommates to afford a place is impractical. These are undergraduate and graduate education students who chose to come to OSU Cascades to prepare to teach in our community schools and make Central Oregon their home. Their every intent has been to stay in Central Oregon, and in some cases, in all cases, return to the community. Sorry, let me say that back. They come to Central Oregon to teach in our community, and often they're returning to a community in which they grew up as well. And they want to raise their families here. They want to contribute to the social and economic well-being of their chosen community. They can no longer afford to realize their dream. I am also hearing of exodus from our alumni currently teaching in Central Oregon, who are leaving due to the impossible financial future. A teacher at Crook County Middle School, an alum of ours in Prineville, relayed the following story behind his exodus from Central Oregon. This is before. Here we go. The first part of his story starts with the slide that you have, talking about the primary reason is financial. His story: we were lucky enough to buy a house before the recent spike, but our 1,400 square foot house with only 1 bathroom does not meet our future wants and needs for a family of 5. And around here, we can't afford anything better. My current salary is only $43,000, and the maximum salary in Cook County is $74,000. In comparison, every district I've researched in Connecticut has a max salary of over $100,000. And if I got a job out there next year, I could expect about a 20% raise compared to my current salary. The most significant part about this reality is that the cost of living in Connecticut is cheaper than Oregon, particularly housing costs. My small house in Prineville is worth between $350,000 and $400,000. In Connecticut, $350,000 will buy you a Taj Mahal in comparison to what it gets you here. Yet they pay their teachers significantly higher wages and invest way more in resources into their public schools. Couple this with a trend, with the fact that the nation is in the midst of an unprecedented school staffing crisis. This slide from the Department of Education shows the projected supply and demand of teachers nationally through 2025. Think about how difficult the recruitment of school staff is going to be in general across the nation, and how the impact of limited and affordable housing will be viewed by potential educators when they consider their ability to attain a quality of life here in Central Oregon, the reason many of us choose to move here. This will also greatly impact Central Oregon and its ability to retain educators as regions across the US move to provide housing to support our middle-class essential workers. Indeed, in a very recent February 2020 national survey, the National Education Association, which is a prominent and predominant professional association of teachers in the US, found that 55% of the current educators across the nation are thinking about leaving the profession earlier than they had planned, with the majority of them ending at the end of this year. The NEA summed up its findings in a stark message: where affordable housing is hard to find, so are all the educators. Across the US, lack of affordable housing is exacerbating the national shortage of teachers, school bus drivers, and paraprofessional educators, and regions are starting to address the impending shortage. Damon Runberg, who you might know, is a regional economist, and he analyzed a scenario for home buyers in the Bend area, utilizing the US Department of Housing and Urban Development ratios of house ownership to income. By HUD definition, when a household spends between 30 and 50% of their income on housing, the household is designated as being cost burdened. Keep in mind that starting teacher salaries in Central Oregon range from $43,000 to approximately topping out at $85,000 for a teacher who's been in Central Oregon for many years teaching, with the average teaching salary currently in the Bend Pine School District at $62,385. Remember that teachers and other essential workers and professionals whose jobs cannot be outsourced earn approximately 20% less than other professionals, such as engineers. Mr. Rumberg determined that with a 20% down payment in the Central Oregon area, you need a household income of around $70,000 to buy that Bend starter house if you are spending 40% of your income on housing, and 40% puts you at that cost of burdened level. With a lower down payment, you'll need an annual income of 85% to 92%. The rental story is not much better in Central Oregon. That had some rental analysis on it too, on the slide. A Central Oregon Regional Housing Needs Assessment Overview report in 2019, which I remind you was pre-pandemic and pre-kind of explosion of what's been happening, found that nearly half of Central Oregon renters are housing cost burdened, meaning they spend more than 30% of their income on housing expenses. Over 1/4 of the renter households here spend more than 50% of their income on housing. Projecting current trends out to 2028 shows that in general, housing needs, particularly those designated as cost burden for many incomes, will worsen. Within the next 6 years, over 14,000 households with incomes between 31% and 60% HUD area median family income are expected to face housing needs by 2028. Many adult professionals in essential worker positions are struggling to carve out a future in Central Oregon due to the high cost of housing. Central Oregon loses talent when these greatly needed professionals move to more affordable areas to start and continue their careers. The region's housing options for people of moderate and middle incomes lack supply to meet current demand and future needs. The supply of vacant and available housing across the region is remarkably low, and short-term vacation rentals are thought to consume a portion of the supply that would otherwise be available to residents in some of the areas. Permit activity for new housing stalled as a result of the Great Recession and COVID, and lags behind the rapid population growth in the region. Increasing production of new units is a part of the solution to this gap, but the level of production would need to far exceed current rates, which is challenging because of high development costs. I know this is not new to you. Your commission and several of the other bodies that you represent or have been elected to are grappling with this systemic issue in many ways. My point is to try and bring to you the perspective of a class of educators, essential workers in our community. So I speak today primarily of educators, future and present, although I have heard similar conversations with others who note difficulties in recruiting essential workers for all of our community, nurses, firefighters, police, for example. Imagine a future Central Oregon without these essential workers. Think about the impact that will have on businesses that wish to locate here if we can't educate our students. I urge you to act to ensure that our children receive a quality education that will produce the thriving citizens we so value in Central Oregon. Increasing the supply of specifically designated housing types, such as workforce apartments and mid-level affordable houses, is critical to the healthy region we all love and call Central Oregon. And I thought I'd leave you with reading a pretty detailed, well, semi-detailed quote from another student who casts an interesting picture on life when he moved here a decade ago. I moved to Bend a decade ago at 25 years old, and I absolutely adored the city. I got an apartment at the base of Pilot Butte for $675 plus utilities a month. At the time, I was an older adult caregiver at a nursing home, and at minimum wage, it was still comfortable living and I could make ends meet. Fast forward 5 years when I started back at college, and I have had to live in 4 different friends' houses, once in a garage and once in a shed off the main house. As I finished my master's degree, my new wife and I live in our friend's place with their 2 daughters, needing to share the other bedroom. We cannot afford to live here, even though we have both been working throughout this time. And he is another one of our excellent graduates to be, who is moving away. So I know I'm under my 20 minutes. I'm open to any questions you have. I have shared a copy of this slideshow with Camille, I think, or I hope I said that right. Is there anything else that I can provide for you?
Thank you for presenting, Carolyn, from the perspective of education as a whole, and then specifically, I think, just the challenges of being a student of higher education in any state, and definitely in Oregon. It's interesting because my husband is a Bend Lapine public school teacher, and he was hired in 2017. And he was a part of those very competitive, intensive job fairs where you were just so lucky to get an interview. And I'm just reflecting on that, that was not that long ago, and how much the tide has turned. But I work at St. Charles in administration, and everything that you are presenting is completely comparable to what we're experiencing with, what we used to think of as highly paid technical workers like registered nurses. And what's happened over the last, 18 months is that the demand in their cost of their labor has increased, 20%, 40%, sometimes 50%, depending on the area. And it's just the cost burden doesn't even pencil out, right? Like we're trying to reduce the cost of care to Oregonians, and yet the cost of providing that care is just being driven up dramatically because of the price of labor. So it's just, the economists must be puzzled by all of that, of how to get out of the mess. But the only other thing I would add to this, not to pile on of problems, but the combination. So it's often these issues are like the complexity and the brunt of it is the combination of problems. Because when you combine housing with childcare and the lack of childcare, it becomes just like now, like potentially 90% of your income is being tied up, right? In being able to go to your job because of the need for someone to watch your infant or child, and then of housing. So it's a real mess. And I would love a regional solution in which St. Charles is and will be a good partner in it as the largest employer. But just wanted to share those initial thoughts.
Thank you, Iman.
Hi, Carolyn. I have a question for you. What other platforms have you taken this to? Like, for example, city council and things. I'm just curious. And because obviously this just kind of highlights, this is across all spectrum of professions in our area. And this is really going to impact just what we become as a community, And so I was just wondering, what your experience has been and where the conversation, I know, just for us to think about, okay, so then where are there opportunities to bring broader conversation through all these other sectors? So if you can, I don't know if you've, where else you've kind of had this.
You are my guinea pigs. So you have been my first stop. Linda Johnson and I have spoken just on a book club personal background. Be careful what you say during book club because she brings you forward. I think it's an important message. And, as I pulled this together, thinking about what could be important to a group of representatives such as yourself, really with the best interest for healthy communities in mind. It is stratified, it is systemic, and it is multiple, as you were saying. The answer needs to come from multiple areas, including partnership of the school districts too. I have examples of communities that have recognized, maybe been forced to recognize need for supporting teachers earlier than we have. Palo Alto, Silicon Valley, a few of the high, impact areas from tech workers, for example. And they have, over the last year, San Francisco Unified and Palo Alto, for example, have started, have come together as communities and partnered with schools and with legislators in the state to begin building affordable housing for teachers with 7-year commitments and buybacks. Other districts are using, are with the state pooling together or community pulling together down payment that can be borrowed and amortized over a number of years. There are a number of creative solutions that are occurring, but it's going, as you say, Divya, it's going to, require many of the groups that care about Central Oregon to come together and think through this systemically and interactively, I think.
Thanks. That helps because it gives us some kind of idea of, if we think about, okay, well, what do we want to do and the role? So thank you.
You're welcome. Aspen, a great one, great model. I mean, those have and have nots, they're workers. The essential workers in Aspen have been commuting, 2 to 3 hours to get in to teach or, be part of a community health system, for example. So Brad just put that up in the chat if you haven't seen it.
Carolyn, go Brad, sorry.
I was just going to ask Carolyn, so you presented a bunch of research data on the problem. Who's doing the research on the solutions?
I don't know. I can tell you, I've pulled from national. I think that's a great question. And I guess my reason for becoming alarmed and bringing this to you all is that I hope that we need to start somewhere, right? Somebody's got to start doing this. I am an observer. I am a preparer. I am an educator. I'm passionate about our community. I've lived here 25 years. And I am not one of those to say we have to shut the door, right? We've grown so much. I've seen it grow decently, but we have reached a point of where I've started becoming alarmed as to where our educators are going to come from. And we've already lost, through COVID, 2 years of some really good learning. In Oregon, I don't know if you know this or not, but this year there was such a lack of substitutes that in early October, they removed the requirement that substitutes on emergency license to go in and just sit in the schoolroom did not even need to have an undergraduate degree, just so they could get bodies in the buildings. So part of that is, there are many aspects that are coming together to create this crisis, I think, that we're about to hit. What I urge is that Central Oregon start to really, the time is now to move forward. I've seen in the last week, even I've seen some really good starts in the bulletin and various places. League of Women Voters has also done a study. I have not yet gotten a chance to see it, but of affordable housing for mid-career professionals. So I would direct you there. I think it's going to probably be very good. So I don't know. Good question, Brad. Let it be us.
So there is a lot of work that's happening in the region right now, especially between Deschutes County and the cities too. So Patty, I wasn't sure if you wanted to I see that you're off mute. I wasn't sure if you maybe wanted to comment.
Tammy, yes, I did, because I thought this was so relevant. We allocated almost 8 million in county funds in the ARPA. Can you hear me, Tammy? I'm in here in the dark. Anyway, 8 million, and the state actually did more than 8 million for Central Oregon. So we have about 16 million. And I know the 125,000 that we spend at COCC has been put to use amazingly with Spanish and English classes. It'll be on to the third term of that shortly. And then we just did the Simpson property for 110 units, affordable units. We just did a huge 190 homes in La Pine through DR Horton, and those homes will be built. Hopefully their plan is to build pretty fast. So I feel like we are trying to do as many things. I know it's a huge problem. I know affordable housing it's hard to find, but between Habitat and CORE, we and the Simpson property, we really have tried to step up as much as we possibly can. So thank you for giving me this opportunity.
You bet, Patty. Thank you so much. Carolyn, go right ahead.
Patty, thank you. And that's some of what I've been seeing just this past week. And you just appreciate that work. I guess I would like all of you to remember and not to minimize any of the work that's being done for homeless and very low income people in this community. It's so important and crucial. What I'm trying to represent is that it's that next level who may not fall under the affordable definition of low income. These are your mid-class professionals, and I think it's a step up. So yes, we need more housing in all of these areas, but how do we guarantee that some of these essential workers that we need in our community, the nurses, the firefighters, the police, the teachers, and there are others, also could qualify for some of this housing?
So Trisha and then Megan and then Linda.
I just want to take a moment. I know I'm a guest in this space, and thank you so much. I just wanted to really echo what Justin was saying. I lived in Park City, Utah for 17 years. These conversations came earlier to resort towns. And I would just really encourage us to look for some of our solutions in creative spaces like Sun Valley or Vail, Colorado, or Park City, Utah, that due to those being very desirable places to live, people were squeezed out of places, and organizations were squeezed out of commercial places. And, Planned Parenthood had to relocate out of Park City to neighboring towns. And I lived this cycle there that continues, and a lot of action across organizations and partnerships really made a significant difference in these spaces. So I just really wanted to give kudos to that conversation, because while this is new-ish to us post-pandemic, we were already rising, and we have risen here once before. But again, in those places we could see there, Brad, I think there are some solutions that we could look for. And then I just want to thank everybody who works and thinks about this housing challenge every day. I can hardly think of a day that doesn't pass at Pacific Source where we aren't having some conversations in this space.
Thank you. Megan.
One thing I think that I'm curious about is the ecosystem of different groups working on the housing crisis and thinking about our role in that context, because we have the regional housing group that I think is even more structured now. We have Housing for All, which may not be quite as structured. Then we have some of the groups that focus on more of the shelter, low income housing, and then thinking about, so from a health council's perspective, what role can we play in this to augment and facilitate the work that's happening regionally? And I do think one of the areas that we could help with is really highlighting housing as a determinant of health, that interrelation is really critical. And I don't think people always think about it that way. And maybe there's a role for the health council to really solidify that for our community. And then just what's the environment, and where do we, fall into the other work that's happening, and Katie Brooks at the chamber, also work happening there too.
Your mind is going exactly where I was hoping that it would go. And so thank you. Linda, go right ahead.
I've been thinking about this a lot, and this discussion is helping me to realize that the issue of housing as a social determinant of health is really a continuum, with one end stable housing, the other end, the extreme end, would be houselessness. And what Carolyn's been talking about today is somewhere in between. And I think there are many points that the council and the community may have a role in intervening. If we can make housing more affordable for people who are working full-time professionals, then that can help prevent and alleviate and stop the flow towards the extreme end of the continuum. The other thing that I'm impressed by is how, as a social determinant of health, the Health Council's success is interdependent with our community's ability to solve and to recognize and to alleviate this problem on housing. We can't be successful if that's not done. So it raises, for me, it raises the stakes of the council's role in our own commitment to improve community health, and how and what our role should be engaging with one of the social determinants of health.
Agreed. Mike, were you wanting to make a comment as well?
Yeah, I belong to the Redmond Economic Association, and one of the conversations we're having over there is water. And this is directly related to housing, because 80% of the water goes to irrigation. And there's not, I don't know if you folks know it, but in the early 1900s, all the water in the river were given away to the irrigation irrigation companies, and so they actually gave away more water than there actually is. And so there's a great debate about how much agriculture we're going to give up so we have enough water for the people that are coming, which directly relates to the issue you're talking about. The other thing about it is I've sit on budget committees, planning commissions, city councils, and I've actually served on here. And this to me is a cultural thing. I have just sold a house in Alabama, which was 4,000 square feet. Here would be about 750, 800,000. I paid 382 for. And when you have a piece of property there, you go in to say, what can I do with it? They say, it's your property. Why are you asking us? And so there's a real difference in philosophy about what are we going to do with the land. For example, a system development charge in Alabama is 5,000 or less, and here it can range from 19,000 to 30,000, depending on which city you go to. So a lot of it has to do with the choices we, as a community in Oregon, have decided for ourselves, which is we're going to, I don't like to use the word regulate, but we're going to have ideas about how we ought to plan, and that costs money, and we're coming to a clash to that. And I think the overall picture of it all, I can still remember in 1972, I believe it was, when LCDC came around, and I asked this question: how is this going to impact the cost of housing? That was in 1972. And they said, well, it won't be a problem because there'll be flexibility to have lots of land. I was also the chair of the Deschutes County Planning Commission when we did Redmond and Ben's urban growth boundary. And I don't know if you remember during the Great Recession, how they said in Bend that we'll never need this amount of land till 2050. And we're already there. So there's a lot of issues that are bigger that have to do with the cost of housing. And there's also culturally about how do we look at our communities, which is a big issue also. Thank you.
You raise some really good points and also underscore the broadness of this issue. And so my hope for us is that we are thinking about our role. And when I think about the Health Council, I think about the education that we provide to the community, the advocacy that we have done in the past, systems alignment that we've been able to help shepherd or sort of guide, planning efforts, making sure that those systems are aligned and planned, seeding projects or good ideas to bring things together, and then leveraging resources. And so and those are just a few that are top of mind of for me. But so next, I think it'd be helpful if we hear from Donna on some of our current investments. And then all of this is, and Carolyn, yes, you're welcome to stay if you'd like.
Well, I think I need to get going and get
Okay.
my other work done, but thank you very much. Sorry. didn't mean to
What a
interrupt you.
gift you are. Thank you so much
thank
for
you.
being with us today, and excellent presentation.
Thank you very much. I appreciate having the time. Thank you for asking me to come.
Of course.
All right, take care.
So Donna, may I turn it over to you so that we can get a feel for the great work that right now is happening under the RIP work group. And Megan teed us up. There is a lot of work that's happening in the community right now. The regional health, or the housing needs assessment from 2019 that was also mentioned. There are a lot of efforts. But if I were to say there's maybe one thing that's not entirely cohesive is the tying together of some of that. So Donna, I'm going to turn it over to you. And what is it that we have invested in so far?
Yeah, thank you, Tammy. And boy, just the stark realities of, of the growing pains of the lovely place that we get to live. So I thought that I talked to Tammy and Linda a little bit about this, and we thought that it would be valuable just to bring to the board and the community that's with us today, really what we have invested in as the Health Council. And really, I don't think it could have been said any better. I just want to take you back a little bit to our previous RIP, the one before this particular one. And I think it was 2016 to 2019, but we were just dabbling in social determinants of health then, and we had to pick two. And we picked housing and kindergarten readiness. And so this first part, this top part of the report, I draw your attention to we spent almost $3 million in those 4 years of that RIP. And because the 1115 waiver didn't prohibit us from building, we were able to invest some money in building. We were still a little bit gun shy though, because as probably most of you know, the federal government does not like anybody but themselves dabbling in HUD and HIMSS and all those places where they're actually building. But we did, and we helped with the capital campaign with Bethlehem Inn. We helped with the Azimuth 315 apartment building, which is just beautiful and still stands today. Pfeiffer and Associates renovations of 2 condos, and that was for safe, sober living. And then the other 1.1 would have been in programmatic type of things. So one of the things that remains today to be true is we can't build, we can't pay your rent. So those are 2 places that we clearly can't actually give any money to support. Now, we are very, very creative in what we do, as most know. So we had that housing work group back then. Now, one of our 6 work groups is stable housing. And that stable housing is also been working with our addressing poverty, enhancing self-sufficiency work groups to actually expand, or maybe the proper explanation would be to get deeper into where we can help and where those systems can get changed. And so this is why I'm really excited that the Health Council is having this discussion now, because is there a place we're not looking? Is there a rock that has not been turned over that has the proverbial magic bullet for us to move forward? I think most of these organizations that you can see here are very familiar to everyone. And interestingly enough, they all do intertwine. So I just want to make sure that no one thinks that all these organizations work autonomously, because they don't. They work with each other. I just wanted to bring your attention to the spend so far is year 3 of 5. We just started year 3. And of course, I will remind you that due to COVID, we were a little slow in getting started and getting funding into the community. But these are the investments that have been made to date. So that's that 1.7. And again, part of those monies are coming from the stable housing work group, and some are coming from other work groups. So they're working together to bring these innovative, some just because we need them, right? But others that are really just getting off the ground. And Tammy, to your point, where we've had the opportunity to seed some of these organizations, some were seeded and put the brakes on and said, no, we were going the wrong way. We want to work over here with these folks. So I think, as you all know, none of this turns on a dime. We continue to work on it, but I'd love to hear the brainstorming of the group about where we might want to focus or bring more attention to our stable housing work group. They're always welcoming and inviting folks in to really looking for new answers, right? I did ask Gwen if she would just share just a moment on what the current work group environment looks like and what they've kind of got in the hopper. And I think I convinced her she can't share everything because some of it's not for, prime time yet, but she agreed to give a great overview of what was happening.
Absolutely.
Gwen?
Yeah, the housing, it's stable housing and supports. And so they've been really working, and the future state measures have really driven some system level work. In addition to the investments that you've seen that they've made in this current RIP, they're currently exploring some inter-organizational coordination to focus on education, outreach, and advocacy strategies to really address one of the big barriers to affordable housing and houselessness, addressing the public bias against people living houseless and seeking affordable housing. It's a known barrier in many of our communities. There, in this work group, there are multiple established housing-focused organizations working on different and complementary components of the housing crisis here in the region. Many of these organizations already convene monthly on this stable housing and supports work group to collaborate and coordinate efforts among and with each other. Some of them, you've heard the names before, even in this meeting. They include Housing for All, Housing Works, Homeless Leadership Coalition, Fuse, and many others. They meet the third Friday of the month, 10:30, which actually happens to be tomorrow. If you're interested in hearing more, you're always welcome. They're open to the public.
Thanks,
So
Gwen.
they're busy cooking.
Yeah.
Okay, well, thank you. And I appreciate the board's interest in becoming informed on some of the efforts that are happening in the region, as well as sort of helping me guide this forward. And I guess the question to the board is, our May meeting is going to be dedicated to really embracing Carmen and making sure that we can integrate her into our work and get to know us. And so I'm looking at our June meeting of carving out time to talk about maybe some strategies or things that we might want to be thinking about in terms of aligning ourselves in some of the areas in which we maybe do best, which is there's a tremendous amount of funding coming into the community right now to offset assistance for rental, for down payment rental assistance, utility assistance. There's certainly never enough, but I would submit that that's really strong in the neighbor impact wheelhouse, and there's we have partners that are already doing that work. But are there gaps maybe that we might see or that might be presented in terms of being able to really leverage our voice as a health council into this public health crisis and in a meaningful way, and maybe also assist in aligning some of these efforts to leverage them as well. And so I'm going to pause there because I don't want to, I'm our tour guide, but I'm not, I'm one of many brilliant minds here. What is this? How does this sit with us as a board? Are we feeling like this is something that we want to be more aware of and involved in, or are we wanting to continue to keep this at the committee level and remain informed through those pathways as well, or both? Or none of the above? Or maybe someone does have the answer.
Yeah, I wonder, could it be helpful for us to have a little bit more of an understanding of some of these other entities that have been lifted up and see what's the regional housing group, what's their role, what's the Housing for All, what's the chamber's role? And Patty described some things, the big things happening within the county, and then we could see is how do we fit into that housing ecosystem?
And I'm happy, Donna, go right ahead, or Linda.
Yeah, I was just going to add the report that we created. Thank you, Rebecca. Me and Rebecca in my pocket that was able to actually bring these numbers together is out of our grant platform, and it has a mega amount of information about the detail behind these plans and behind these grants, but it's just really big and unwieldy to send out in a board packet. So I'm just am more than happy to send some of this backup out so you can all see what these programs are and what they're trying to accomplish as part of doing your due diligence.
And
Linda.
Tammy, I don't have the answer, but there were two things in this last 5 or 10 minutes that have really stuck with me. One is when we look at our current investments in energy and the community's current investments in energy, it tends to focus, I think, on actionable things around housing and making that more affordable or available. Someone made the comment earlier that if we had sufficient childcare facilities, parents could work. There was an article even today in the paper that many parents want to go back to work, but they don't because it's cheaper to stay home than it is to try to get a childcare spot. So that to me is another indicator of a system connection. And then the other piece is, it's gone out of my brain now, but there were, oh, the piece that Gwen just mentioned about community bias. And perhaps that education as well as the childcare, maybe that's a connector role for us, because we do have some investments in childcare. I'm unaware and would love to know more about the community bias. And perhaps at a policy level, that's one potential role for the council.
There
Okay,
is.
I'm curious to know about any efforts that are specific to middle income folks, because it seems like the emphasis is on low or very low income. And I think in my mind, it ties in closely to our desire to increase the diversity of our workforce as well. So it goes hand in hand. Like I said earlier, all of these are so intertwined, but the more expensive housing is, the least likely that you're going to be a person of color wanting to move to Central Oregon, if you're going to struggle across all many aspects of it, right? So I don't want to get lost. I don't want to lose the emphasis on the police officers, the teachers, the nurses, the folks that are part of our health, providing health to the community workers, that I think that our natural cultural empathy for them is pretty not towards wanting to help invest in them so much. We love them and we support them, but yet we kind of roll our eyes when we think about affordable housing for that group oftentimes. So just wanted to, I don't know if it's a policy statement or a belief that the council could craft and then, energize our efforts with the chamber and these other entities in the community.
Iman, I think you are spot on. And there is a lot of work that's being done in that middle income section as well. And it might be good. There's a graphic that actually has, although it's not perfect, but if we don't let that get in the way of the good, it shows who's doing what in which spectrum of this issue, because really housing is, we have individuals who are unhoused, getting them into housing moves someone either out of that housing into different housing. We need to have that housing. And we have individuals that are in housing that are in the wrong, they're in the housing they can afford, but if we could get them into other housing that they could afford, home ownership versus being in the rental market, that frees up the ability for others to get into the rental market so that it's this domino effect across the entire spectrum. And so that graphic, again, not perfect, may give us the visual of kind of the complexity of who's doing what. And I also, as an example, when there was the House bill going forward with the pilots, the housing pilots, which gets to Mike's comments around the land use laws that we have in Oregon. And so allowing for some piloting. So Bend was selected as well as Redmond. That might have been an area where we might have leaned in as a letter of support, or maybe even legislatively testifying to be able to share the importance of housing as a social determinant of health. And so those, in my mind, those are just examples of ways in which we, without even spending a dollar, could maybe really impact some of these efforts that are happening as well. So if that helps to get to Megan's question of, who's kind of doing what, there is a lot that is happening currently. But it does feel that there is an appetite to tie it together. If we were to ask, what are we using as our shared goals for success? I would submit that there isn't necessarily a roadmap that is being used with the organizations to be able to say, and here is what we hope to achieve. Each individual organization is looking at what success will look like for their own needs, but in terms of pulling it together of how does that solve the issue across the spectrum. We have what's called High Desert Home, which is the 10-year plan refresh that happened around 2015, but there hasn't necessarily been a regional playbook plan or a work plan or any sort of a strategy that ties all these really meaningful efforts together and sort of leverages them in a regional way. I would also hope that at some point, if that were the direction, we'd have a chance to embed that into our own strategic planning and be able to really take this as a playbook to address some of these issues. I think it might have assisted some of our local elected officials when they had an opportunity, when $39 million lands one-time funds into community, and the community isn't necessarily prepared with a roadmap to say, and these are the investments that would be incredibly meaningful. It becomes sort of fragmented. I think we've had great success with all of our investments, but I do wonder if maybe there's an opportunity for us to pull some of that together. So I see a furrowed brow and some heads nodding. And so how does that sit? Should we maybe bring the graphic back in June? Maybe bring a couple partners? Does anyone want to partner with me to tee this up? What are we missing? Linda's raising her hand. Yay, partner in crime. Carmen's raising her hand. Yay, okay. Okay. Well, is there more that Brad too? Yes. Does anyone have comments? Are we headed in the right direction, or are we Thelma and Louise going off a cliff here?
Yeah, I just have to share what I'm feeling. I think the main thing is the Health Council can't do it all, right? So we have to prioritize, we have to identify, be specific about our role, identify where we can make a difference and where we can't. And there's already people have said there's a lot of people working on housing. So we don't need to be another people working on housing, I don't think. I mean, trying to solve the problem necessarily. We can be a part of it, or members of the Health Council can be a part of it, but we don't need to be yet another entity trying to solve housing if there's already several entities who work on this every day trying to solve housing. So I just want to share that. Having said that, being informed is good, but we would, being just one more voice saying housing is a problem doesn't really accomplish anything, I don't think, because there's lots of people saying how, lots of people know housing is a problem.
Yeah.
A challenge here in our region. I think I'll just stop there. So yeah, it gets back to really identifying where we can make a difference and prioritizing.
Agreed. Thank you, Brad. Gary, dive in.
Yes, and I apologize again. I was not able to troubleshoot my camera, so I'm going to be off camera. The last thing it said in the troubleshooting menu is reboot, and I have too many windows open that I couldn't really afford the time to do that. So I'll work on it later. Apologies. But, I don't know if I'm speaking for myself or others feel just incredibly overwhelmed by what I'm hearing here. And certainly, we all, Iman spoke to it very well about how we, within our own organizations, feel the effects of the housing crisis, what was shared about teachers, what was shared about the hospital employees. I could tell stories about, dental employees and dental assistants who are in the bottom end of the salary structure within a dental organization. And, it's totally overwhelming. And I guess for my interest is, it seems like we are investing in things. I would like to know, are we, and that is, I think, a role that we can play, but are we investing in the right things? And to be able to weigh in on that, I would certainly need to understand better. This, I think, is just the tip of the iceberg. Thank you.
Agreed, Gary. Thank you so much. So how about Donna, if we work offline with Linda, Carmen, when she's available, others, if you want to signal interest as well, frame this up a tad, use some of the existing documents that we have, maybe take a peek at some of the outcomes that we've been able to achieve so far with the investments that we've made. And then I think it'll show in this system where the investments actually are, because they'll be, they'll show up like a city on a map. They'll show up as, areas in which, in the spectrum that we are investing. And then maybe we could take a stab at suggesting some areas that may be gaps, And that could be also brought forward maybe with some of the partners that are doing the work themselves that they see would be meaningful. Does that work? Okay, wonderful. And anyone, am I getting it? Am I representing your will as the board in the right way? Kind of seeing some heads nod. Yes, okay. And we'll get to see where some of the gaps also and what's being done in the workforce side of the equation too. So thank you, Dan. All right. So with that, anything else on that topic? I'm encouraged by the interest and not surprised at all. I know that this is something that we just, see it every day and want to do what we can to be, invested in helping to make it better. So next I'm going to turn it over to Megan and Carly, and let's talk about Project Access Now. So all of the boxes are moving around. So there you are, Megan. Okay, go right ahead. The floor is yours.
Okay, well, first I'd like to welcome and introduce Carly Hudronic, who's the Executive Director for Project Access Now. And she's been in that position for 1.5 years. I always say 2 years, but it's been 1.5 years. And the organization's been in existence for 15 years. And then she also has with her Joe Ickcher. I'm hopefully saying that right because I haven't gotten to meet him yet either, but welcome, Joe. And he is the Director of Community Benefit, I think, for Providence, Oregon. And he is a beneficiary of Project Access Now as far as the health system, but also on their board. And why we wanted to bring this topic today is that in the Portland area 15 years ago, health systems came together, understanding there was a significant need for folks who were uninsured and low income. And they came together and started with creating donated services so folks who were uninsured would have access to the care that they needed. And since then, the Project Access Now has grown and it included multiple other programs that really help this population and have become quite essential in the Portland metro area. I think some of us in the region have kept our eye on Project Access Now because we do have an uninsured population. I know at Mosaic, we have close to 4,000 lives who are uninsured. Volunteers of Medicine Cat, I think you guys have about 1,000 lives. There are other folks who are uninsured. And then I think we've all been sort of observing the information from the state with redetermination looming, where we could have close to 12,000 to 20,000 lives coming off of Medicaid. There are a couple of state programs, but they're not going to be able to solve the whole uninsured wave that's coming to us. And so some folks have been reaching out to Project Access Now from different organizations. And I think we've started to have some generative conversations with different entities and looking at, gosh, could we explore our need here in Central Oregon? And could Project Access help us meet some of the needs that we have here with some of the capacity they have to potentially expand into other parts of Oregon? So with that, I'd love to turn it over to Carly, and she's gonna do a much better job describing Project Access Now and what they're able to offer. And then we'd love to open up the conversation to see if this is something that we'd want to continue these conversations and really start to understand the need in Central Oregon and this potential opportunity. So Carly.
Perfect. You teed that up perfectly, Megan. Hi, everyone. I am Carly Hudronic. Trying to make sure my internet is not slow. Can you hear me okay?
Yes.
Okay. Can you see my slides?
I cannot, but can others? It says you're
sharing. Yeah, it says that you're trying to start your screen. Oh, there they are.
Perfect. Okay, great. So I am going to run through kind of the foundation of Project Access Now, who we serve to exist, and then I'm going to, and our suite of programs that could be an option to talk about in the Central Oregon area. And then I'm going to turn it over to Joe, who has been involved with the organization for a long time and also sits in the health system space and can articulate some of the values that he has seen with regards to the program. So I'm not going to let Joe introduce himself just yet, but he'll get to. So we are a nonprofit serving the metro area in Portland. We are Project Access as a model is not actually unique to Portland or to Oregon. The first version was actually born in North Carolina in 1996. And today there are roughly 14 similar models around the country that really serve to provide a safety net of donated services to individuals who are uninsured. What makes Project Access Now, our version, unique is that our suite of services go beyond just those donated care slots. So our mission here in the Tri-County area is to improve community health, creating access to care and resources with a specific focus on those in need. Megan already mentioned, we were lifted up 15 years ago as a partner to the health systems, really a utility to help remove the administrative burden on the systems and to provide better support for the underinsured and uninsured in the region. Today, we convene representatives from each of these systems monthly, and they really look to identify collaborative opportunities to for PANA to come in and fill gaps regionally. I think we are pretty uniquely positioned, like no other entity in the region, in that we sit squarely between those health systems that fund us, and we attempt to deliver on strategy for, and the community clinics, government, state and local government, and increasingly a number of social service entities that we partner with to make sure the same population has more than just access to healthcare, but access to the social resources that keep them out of the system in the first place. So we have 5 key lines of business under our roof. The first 4 are our key programs. So the classic program, which you see up in the top left, is our flagship effort that began in 2007 and is the program that I think most folks think of when they hear of Project Access Now in our region. Through this work, we connect low-income uninsured clients to the donated primary and specialty care they need. So we receive a number of referrals from FQHCs like Mosaic, private clinics in the region, health systems, and we really act as a clearinghouse to help patients navigate a network of over 2,000 providers who donate a variety of different resources and care spaces for them. We are not a clinic ourselves, and we don't operate as one. So I want to be really clear, we don't have a clinical team, and we don't move around in the region providing clinical resources. We're more of the clearinghouse space. So at the same time, 2007, that program began, and we recognized, patients who are uninsured can't go to a specialty appointment and be prescribed, or a primary care appointment and be prescribed something and not able to afford it. And so we lifted up a pharmacy program that supports adherence to treatment plans by offering low or no cost medications to those individuals. About 7 or 8 years later, the team recognized the need to, or the desire rather, to be able to support individuals who may be eligible in getting access to stable, long-term healthcare, rather than just a one-on-one, one-off donated service opportunity. And so we lifted up our outreach team. Today, this is our biggest team. They are out in the community assisting individuals in signing up for OHP specifically. And they are also the team that is becoming certified as community health workers to be able to help those patients navigate other eligibility for services if they're being screened for Medicaid. That team then quickly saw another gap emerge. Some of the clients that they were trying to enroll in Medicaid made too much to qualify for Medicaid, but still could not afford the premiums associated with a marketplace plan. And that is the exact population that stands to suffer from redetermination. So we went back to the systems in 2015 and said, hey, there's this sweet spot population that is experiencing either a lot of churn, or they are just ineligible for Medicaid, but they can't afford coverage. And so the health systems bought into that program. Through this, we offer to pay health insurance premiums. Those patients can pick, clients can pick whichever plan they want to go with, and we will pay the premiums for them to make sure that they can stay on a plan under the Affordable Care Act that they otherwise wouldn't be able to afford. And then finally, our last program that developed, and this one we're working in partnership with a couple of health systems and the CCOs, HealthShare and Care Oregon in our region, Through this work, we connect low-income people or members of a CCO with the resources they need to leave a hospital system safely or to stay in their home safely. So often these are not medical resources. These might be a car ride home, housing or rental support, as I've heard in this meeting you're discussing, car seats, things like that, to really make sure folks can leave the hospital, stay home safely, and access follow-up care. So today someone enters our program and we will first identify, do they qualify for Medicaid? If so, they are sent to our enrollment assisters. If not, we want to understand, do they make too much to qualify? And if it's even $1 too much, but they otherwise couldn't afford premiums, we ask, can we help them enroll in a marketplace option and pay their premiums for them? And finally, if they qualify for nothing within either our programs or existing policy opportunities, CAWM, anything like that, we will, and especially if they have an acute need, we will find a donated service for them through our classic program. So that's sort of how some of the programs work within our umbrella. I'm sure you're asking who are our funders. I've mentioned the health system partners. I want to say, you know, I think when I share the model of funding that allows our 35-person team to exist, people are very interested in how we have collaboratively created a space where the community, regardless of if it's an FQHC or a large health system, understands the value of supporting the uninsured in our region, and they're all paying in on some level to make sure that we're collectively taking care of that population. So you can see that our core programming is largely funded by the health systems. Government contracts support a lot of our outreach and Medicaid eligibility work. CCOs are really interested in that social support, the kind of C3 CAP program, and then foundations, clinics, and individuals make up a small portion of our funding pie. So just a couple of positive returns, and then I'm going to turn it to Joe. You know, there's a lot of numbers on this screen, and I will share these slides with Donna to hand out after, but just to give you a quick picture of our impact. Last year, we served 20,000 individuals regionally, and through the prescriptions we filled, the appointments we made, interpretive services that were offered, premium payments that were made, we pumped the equivalent of over $12 million in services and goods back into the community for those in need. And that's certainly not our budget. That's not how much we raise, but we are very strategic and effectively able to leverage dollars that partners contribute to our funding pie. We are beginning to look a lot more at what does it mean when PANOW goes away, right? So what does it mean to pay for something and prevent a catastrophic need or an ED visit? One of the areas that we've begun to explore is how the health systems and the community receive a return on just making sure people are insured. So we partnered with Comagine last year to study what it means for the health system specifically. And we found that over the last 3 years, for every dollar that the health systems put into that premium assistance program, which is the one that just makes sure people can stay insured, the systems specifically received a $2.20 return on investment. So, and that's through claims, you know, again, making sure someone's insured. This model does not acknowledge or account for the associated costs of ER avoidance or chronic illness mismanagement that may have been avoided as a result of making sure someone's insured. It's merely dollar to dollar, what the systems gained as a result of prevention. Some of our work with Kaiser has also shown substantial ED avoidance and cost savings. Through our community assistance program, we help folks leave that hospital safely and in as much allow the system to really stay focused on providing quality of care, a fair number of beds for the patients that need them. In 1 year, Kaiser calculated that we helped patients avoid over 1,600 hospital days, which amounted to roughly $4 million in savings for them. And the cost administratively to run that program on our side was a little over $300,000. So do the back of the napkin there, and it's roughly a 13 to 1 return on investment. And then finally, I'll turn this over to Joe, but I think a huge growth opportunity for us and something we're increasingly realizing people are interested in because of the focus on social determinants of health and how much those factors impact health, we're excited about the opportunity to leverage the vendor network we have built for the health system partners and the folks discharging from the hospital for the CCOs as well. So Care Oregon and HealthShare in our region are both partnering with us to utilize their health-related service dollars to provide transportation, AC units, hotel rooms, CSA food boxes, whatever the CCO needs, we attempt to build that network on behalf of the members. So with that, I'm going to turn it over to Joe. And Joe, you can tell me when you want me to move your slides.
Okay, great. Thanks, Carly. Can you guys hear me well?
Yeah.
Yep, good. So Carly went through all the kind of the core purposes of the programs and operationally how they work. I'm going to talk a little bit more about Project Access as it relates to Providence writ large. I don't have a long history with Providence. I've been with Providence a little over 3 years now, but I've been working in and out of Oregon for well over a decade now. But the P&I core programs, you know, what they offer the health systems, not just to Providence really, is that it's mission alignment and support for the uninsured and some of the most vulnerable in our communities. You know, I listened to half an hour of your meeting prior to us presenting, and it really sounds like what you're doing aligns with a lot of what we do within Providence in terms of community health investment and our mission. So it does make a lot of sense and alignment there. Project Access really has removed a lot of administrative burdens for us in terms of these sorts of programs. It's a suite of services that's targeted at a population that is, you know, it's more difficult to get to that population and more difficult to serve that population than it is just a regular insured population. So they really have reduced the administrative burden for all of us, Kaiser, Legacy, OHSU, and Providence included. And then further program development is identified. As Carly stated, you know, we look at Project Access as a utility. It's a utility with a certain core set of capabilities that as we recognize problems within our own health systems and within those populations, within the community health needs assessments that we do and our community health improvement plans, that we can go to Project Access and collaboratively work with them on solutions to problems. And just some of the things listed there: care coordination, continuity of care for uninsured, ED avoidance, and then of course, legally compliant social support for patients during wildfires, pandemic. That last one, you know, they were able to really pull up the bootstraps and give out a whole lot of money from Multnomah County for support during COVID and wildfires in a mechanism that would have taken another organization months to set up. And it needed to go out the door right then. And they were able to serve that population very quickly and efficiently. And then coordination oversight of monthly advisory committees. We have the health system partner meeting that meets on a monthly basis. I chair that currently. That's the forum where we talk together about issues that we see across our health systems, and then how Project Access is operationally working within the programs that we have them under now, and then how they can be improved in time. Go ahead and flip the slides, Carly. We use braided funding to work with Project Access. That includes direct community benefit. I'm actually the executive director of what's called Community Health Investment, which includes a lot more than just community benefit at Providence. I coordinate with the Providence foundations. You know, we've got something like 18 individual foundations of Providence within the Oregon region. Then we have the St. Joe's Community Partnership Fund in Northern California. And then the health plan, who also does community benefit work and is involved with things like premium assistance and enrollment support. So we really don't do this all through community benefit directly or community health investment, but we look at how we can leverage our different parts to come up with these braided services and braided funding to service the population. The patient support program is one of our most impactful programs, I would say, immediately. It was developed first as what she referred to as safe and secure discharge. And this was another one of those evolutionary things where I wasn't around at Providence at the time, but in 2015, we had nurses who were swiping their badges to pay for, you know, meals for people. They were taking money out of their own pockets to pay for transportation to get people out of the hospital, because we didn't really have a mechanism to pay for things like that. I mean, petty cash is not a good place to take money out of anywhere to pay for these things. Coupled with the fact that CMS has regulations that I think you're not supposed to spend more than $50 in non-medical services per year per patient, or else you're essentially inuring that patient to your health system by giving them gifts, which seems kind of silly to us, knowing what the solutions are in a lot of these situations. But we had to figure out a way to work around all that. And so Project Access is the core of this admin function where they have contracts with probably hundreds of organizations overall, which includes hotels and taxi cab companies, et cetera, to be able to coordinate these services. There's about 500 different individuals at Providence who have access to what's called Track Via, where they can put in what essentially is an order for support services, whether that be transportation, whether that be a child seat, whether that be rental support, whatever is identified for that patient's needs. They coordinate all those things for us outside of our walls, which is great because we don't have the capacity to do that. And we actually, even if we did have the capacity, we couldn't legally accomplish it. Right, Carly? Within the patient support program, we keep track of who we're serving in it. As you'll see, it's a pretty even split male-female. Age ranges are primarily between 18 and 64. Pretty good percentage of homeless individuals that are supported in there. Insurance type, income ranges, most of them again are in the 1 to 100% of FPL. Race, relatively reflective of the fact that Oregon in general has a pretty white population. But again, a lot of the people we help are Black, African American. I was a little surprised to see, that even that the ethnicities weren't a little higher in some of the areas, but we pulled out Hispanic and Latino, and then non-Hispanic and Latino in terms of ethnicity, because that's really the largest proportion besides white. And then language, English, Spanish, and other below. The next slide actually shows where the money is going. What's the most expensive services? As just in the slide previously, it said we spent about $1.8 million on services, but what are they? As you'll see, top is just local transportation in terms of pure volume. It's almost half of what we do. There's a lot of instances where we can't discharge people from the hospital simply because they have no way to get to a safe place, whether that's a family member's house, a hotel, or a shelter upon discharge. Second one being just flat out food services. Third being guest housing, hotel, motel, shelter. As a dollar figure, you'll see that's like around $270,000, about 14.3% of total cost. That continues to be one of the highest need areas of discharge because having a safe and secure discharge place for someone to go to really dictates a lot about their recovery. So often we can get them in a place where we can provide outreach services to them in recovery from surgery or from any kind of medical event that they had within Providence's walls. And so you'll see these components. I'm not going to go through them all, but you'll see that there's a pretty extensive list of services we provide through Project Access that corresponds to a pretty extensive contracting network that they actually run for us. Next slide. Any questions and discussion about this? We look at all the programs as an integrated system for Project Access. As Carly went through the kind of ROI examples, we are prohibited from actually doing or asking for ROI on these programs because we do count them as community benefit, and you can't really study something in terms of return on investment for money that you're putting in for community benefit. But they do that independently with Comagine to understand the impact of their programs more broadly than just Providence. So that is kind of a major portion of what we do and how she's looking at things now, because we know that is an important factor. I mean, cost and viability of programs and benefit of programs goes beyond just the qualitative portions of what we see in the populations. Carly, is there anything more you wanted me to clarify in there?
I don't think so. I think Megan and I have had a couple of conversations with several of you and other individuals in the community. I think we had some discussion questions up on the screen. I'm tempted to turn this off and just allow us to be more face-to-face. I'm curious what questions you have, curiosities, anything coming up for you based on what we've shared. And I am going to stop sharing my screen.
I'm curious, have the systems and clinics been thinking about Project Access now role in helping with redetermination in the Portland metro area? Have those conversations been happening?
Well, I can offer what I know, and Joe, you of course from the systems perspective. Yeah, I mean, we're working pretty closely with OHA, specifically as a provider that reflects a lot of the community. Our team is incredibly diverse, speaks multiple languages, and has a good relationship with the Community Partnership Outreach Program at OHA. So we're talking with them about how can we support your vision for what's supposed to happen here. We are also talking in our monthly meetings with Joe and the other health systems pretty regularly about what this is going to mean for the community, and how we can leverage the outreach team and or some of the classic services to make sure people can stay covered, maybe premium assistance so they can stay covered, and we make sure as few people as possible fall off.
And Megan, it's kind of a perfect example of an expandable utility for us, because we look at Project Access as something that can operationalize needs like that. So when we discuss as health systems, hey, we really need to help the community get over this redetermination hump and to get people re-enrolled, what we can do is help fund Project Access a little more robustly in certain areas, and they can scale up relatively quickly because they understand what to do. They have the systems in place to do it, and they've got the community connections with the populations. So really, that they're there for us to be able to fund differentially to expand or contract services as the community needs them.
It seems like, especially with redetermination coming in, I think about Central Oregon, and we have a very creative Medicaid contract, and I think it's favorable, and a lot of entities welcome Medicaid lives into the systems, and many of those entities don't have structures for uninsured folks and sliding scales and things like that. So if there was a pathway to convert the redetermination population to a different type of coverage or one of the state programs, it would create so much stability for us and the population so they can stay with their providers. And the providers can have them stay, and it's okay for their business model too.
Yeah, and I kind of wonder, this is Donna. Hi, Carly. Nice to meet you, Joe. I kind of wonder too how and at what point this will intersect with the Bridge Program Task Force. I mean, I know they've just been freshly minted, but I think that too many times we do things in silos and autonomously, and I just think this is a great opportunity to get in, if you will, on the ground floor and say, we need to know, we need to be able to let all these people just fall off at a particular time is just unacceptable.
Yeah, we're definitely tracking closely when that task force will first meet, which I understand is the 26th now of the month. Yeah, it's absolutely right. We have an opportunity as a state, and until that infrastructure exists, entities like PANOW can help support, step in and fill gaps where needed.
Wonderful. Iman, are you wanting to comment?
Well, I had a question for Joe, kind of just an operational question for Providence. How do your inpatient social workers, outpatient social workers, like the folks that you employ to do this work for most of your patients, how do they interface with Project Access?
They interface through the TrackVia application, and Carl, I don't really know that much about TrackVia. Actually, I'm not involved operationally in
Yeah.
But I know that they have logins. They all have logins, and they can go in and essentially order what's been determined that the patient needs, and then that order goes to Project Access to fulfill, essentially. So that then the communication with that patient also moves from Providence to Project Access.
Yeah, so kind of it's like I bet it's a crowd pleaser for your case managers, social workers. Yeah,
absolutely. Yeah.
And we scope the work to determine what does the system want, whether that's only focusing on transportation or transportation and housing. What is the population that should be eligible for these services so that it's appropriate to your budget? We do the same with the CCOs. If they say we want to be able to serve our members with these things, we scope it, and then we build the tracking system and the tools for your team members, whoever you want to give access to it, to be able to submit those requests. We follow up on them within usually 2 to 4 hours.
Mm-hmm. Mm-hmm.
I think part of the idea was to have the presentation, and some folks have met with Carly and had a little bit of preview time, is this something that there's interest in continuing the exploration to better understand like what's truly the need within Central Oregon, which will look a little different obviously than the Portland metro area, and is this something that we want to look at meeting some needs that we identify?
I mean, from St. Charles perspective, Megan, you can imagine what my answer is. I'd love to know more. I mean, we have, as do all nonprofit health systems, a pretty robust community benefit program. It just sounds delightful to have it more organized and focused, and really trying to be again, I think a just more structured safety net, it sounds like. So I would love to learn more, and maybe Megan, you and I can offline just think of what that looks like on the St. Charles end. But I mean, it seems like others would be interested as well.
I think we met with Kim Bangeter too. He was, I don't know, Divya, if he spoke with you before the meeting, but he was maybe going to try and join today, but his interest was piqued as well earlier this week. It just, because there's the redetermination is going to affect, pretty much everyone in the community that's in the healthcare system.
Yeah, I haven't had a chance to talk to him, but I'll follow up with him for sure. Because this is something that impacts all independent providers for sure.
Kat, would you like to offer some insights?
Thank you. So I have a question too. Some of these components that you guys have up in Portland already exist in Central Oregon. They could be scaled with, enough support, but then you also have some very unique programs that we do not currently have. So I'm wondering if you have any experience or you would consider working within existing structures to strengthen those and build them out, as opposed to bringing in, brand new programs and starting from scratch.
Yeah, absolutely. Our intention is never to come in and take over work that's working well. We actually work really closely with the Volunteers in Medicine program in Clackamas County. Again, we're not a clinic, so we're not attempting to duplicate what a clinic might do. But I think part of if there is interest, part of the next step would need to be a work group or some sort of interested folks coming to the table to discuss what does exist that we don't need to replicate, what are the gaps that no one's filling right now, and what is the population level at which we're talking, because it's very different in Portland. 20,000 people we serve might not be that many in Bend. So I want to be able to have that conversation, and we just haven't gotten to that place yet.
And Kat, that's a really valid point, because we actually, from the other perspective in Portland, we've had new systems come in here, and we're like, well, Project Access already has that, and we're already doing that with things that Connect Oregon's talking about. So let's figure out how to make them more effective and integrated to what we need from Connect Oregon, rather than standing up a whole other, new component that does similar things. So your point is very well taken, and we've seen it from the other side, so can completely understand why you'd want it to happen from your side.
Well, I would really love to be a part of those conversations, because I think our clinic is, one of the key organizations that has been working in this space for, close to 20 years now. So it's something that's near and dear to our hearts, and we would love to see better coverage for all of the uninsured patients in the community. It's just tremendous.
Well, it sounds like there is interest in pulling together a small group to talk about some of the systems that we have, some of the gaps, and how we might be able to partner. So Megan, did you have an idea of what you want that to look like, or do you want me to solicit interest? Do you want maybe, we can have Donna be the receiver of interest, or what do you think is the best next step?
I think if Donna was willing to be that receiver, would be great. And I think that, there's a number of folks today, like Kat definitely would need to be involved, obviously the health system, IPA, and other folks. But if Donna could do that, that would be wonderful, and kick us off with a work group.
And please count us in from the transportation side, although only one slice of that big pie, but an important one too. Okay, well, any other questions or comments? Really excited about this new opportunity to partner and appreciate your gift of the presentation and your time today, both to Carly and to Joe. We really appreciate you very much. And Megan, thank you for teeing this up.
Yep, thank you guys for coming today.
Having us.
More to come.
Yes.
Great. Thank you. Take care.
Of course, yes. Okay, looks like Dan is saying that Pacific Source is interested as well. And so that'd be great. And I don't want to self-select Justin either, but I know that there are some needs there at Summit on the transportation side, if nothing else. So I know there's certainly plenty of interest. So next on the agenda, we have the data review for our health, Central Oregon health data. So I'm going to turn it over to Rebecca Berry.
Thank you, Tammy. Okay, well, Donna asked that I make this as interactive as possible. So I'm really hoping that you all can help me with that. I have a few questions and I'm going to go through each of those. And each person who gets a question right will be getting a gift card in the mail. So I'm hoping that you'll participate. And everyone on this call is invited to participate except Health Council staff. Sorry, folks. You just would get them all right, and that's just not fair for everyone else. So thanks, Gwen. So I'm hoping that everyone has access to the chat function. And then I'm also hoping everyone has access to the internet because we're gonna actually be doing a live search on the Central Oregon Health Data site. And the reason we're doing this is because, you know, we've put a lot of work into adding a number of measures and indicators in this site, and moving forward, this site will be the foundation for our region's health assessment and how we continue to track the efforts in our health improvement plan. And so just kind of taking some time to move around the site and see what kinds of things are available on there. So I'm going to put the link to our site in the chat. And if you could pull that up, the first question I have, and the first person who comes up with the correct answer, I'll take it. They can put it in the chat or yell it out. The question is, what zip code has the largest percent of renters spending more than 30% of their income on their rent? Oh my goodness, Brad, you win. That was fantastic.
Wow, good job, Brad.
I'm so impressed. You are so fast. I'm going to share my screen. And I'm actually going to drop this. Where's my chat? It disappeared. There it is. I'm going to drop the answer into the chat in case you want to look at it on your own screen. So here are renters spending 30% or more of their household income on rent. And this data source, you can always see where it comes from. The source is the American Community Survey. And this is a survey that's conducted nationwide every year. But you'll also see that the measurement period for this is 2015 to 2019. And the reason for that 5-year estimate is because those numbers are more stable if we have a 5-year versus that 1-year unstable estimate. And so the recommendation from epidemiologists are that we do that 5-year estimate. And so here we see that zip code 97739, which is about La Pine and surrounding areas, has the highest percent of people at almost 60% spending more than 30% of their income on rent. And that's followed up closely by 97702, which is part of Bend, and then 97754, which is Redmond. The nice thing about this particular measure is that you can look at it according to the state. So the state is about 50.6, so we're a little bit higher than the state. But when we compare the percentage of our state spending more than 30% on rent compared to the rest of the United States, our percentages are much higher than most other states in the entire country. It's increasing overall in the US. It looks like it's trending down, but I suspect when we get those more recent numbers for 20 and 21, we'll see an increase go up there. Okay, next question is, how has the population for Deschutes County changed from 2010 to 2022? What's the percent change in population? Ooh, you're close, Kristen. Not quite. I love it. Thanks for putting something in. So this is just Deschutes County. Yes, Kat, you win. I got to write these names down. Perfect. So I'm going to put in the answer there. So again, Kristen was really close, but she was actually looking at all of Central Oregon. So here, this type of information can be found in our demographics section. And we can toggle in between different areas to look at data in this section up here. So we can look specifically at Central Oregon as an entire region, Crook, Deschutes, Jefferson. We can even look specifically in Northern Klamath, since we consider that part of our geographic area. And then people can look at it specifically by zip code too. But here in Deschutes County, they've had 30.6% increase in population from 2010 to 2022. All of Central Oregon, Kristen had that 27.92. So Deschutes County is just a little bit higher than the entire region. Great. So next question is, in Jefferson County, what percent of our population identifies as American Indian or Indigenous? Nice job, Kristen. You got it that time. So Kristen guessed 16.42%, and that is accurate. I'll put the answer there and I'll share my screen. So looking specifically under demographics and Jefferson County, and we scroll to race, we can see right here, American Indian, Alaska Native, 16.42% identify. Please hop in if you have any questions. All right, so in Crook County, what percent of people graduated from high school in the total population? Leslie, nice job. Yes. Oh, you all are fast. 33.37% of Crook County residents graduated from high school. There's the answer to that. How is that true? Trisha, you might have to help me understand your question a little bit more.
I believe, Leslie, in your process, when I saw that number as I was pulling it up on my second screen, I just thought, I can't type that, that can't be right. So, okay, our work continues.
Yeah, so, you know, it's interesting here in Crook County, we see 33.37% of people graduated from high school. You can see that number down here. And when you look at all of the educational attainments specifically for Crook County, that's the highest percentage. And so less people will graduate or go on to college, get some college, an associate's degree, a bachelor's, a master's, professional, or doctorate. So high school is the biggest educational attainment for most Crook County residents. All right, next question. In Northern Klamath County, let me write this in here. What percentage of people have a 60+ minute commute to work? I need some other board members here. Brad's kicking everyone's board member tushies. Oh, Trisha's coming in again. She's coming in hot. She's close, but she's yeah, she's got it right, 8.09%. Let me pull this up for you all. So in Northern Klamath, this will be found under the demographics section again, and this is how we toggle to it. So we come down here and we click Northern Klamath, and then we go to the employment section, and workers by means of transportation to work. If we go down here, this will show what percentage, what percentage has a commute to work. And so a little over 8% of folks in Northern Klamath County have to travel more than 60 minutes to get to work. And this compares a little bit differently to, I think it's, let me see, where am I? To Deschutes County, which is only about 3%. So more folks in Northern Klamath County have to travel quite a ways to get to their jobs. Okay, got just a few more questions for you. So in Jefferson County, what is the current food insecurity rate, and how does it compare to other counties in all of Oregon? So the other 36 counties in Oregon. Interesting, Brad. I'm wondering if there's another way to look at it. So this one might actually be not in demographics, but in the search for data section. So our health indicators.
Yeah, Rebecca, I'm just assuming that shouldn't Klamath show up under explore by location?
So in a number of circumstances, we can't include Klamath because the section that we're including would be just northern Klamath, which is a partial county. And sometimes that N, the number of people that have completed that information in that northern part, is too small, so we can't include it. Definitely something we need to strengthen by far. $13.8, Dan, you're a winner. Fantastic. So in Jefferson County, the most recent data from, let me make sure I got this, Feeding America, says that 13.8% of residents in Jefferson County are food insecure. And how does that compare to other Oregon counties? We can look at this measure here. So compared to Oregon counties, Jefferson has a value of 13.8, which is in the worst 25% quadrant of counties in all of Oregon. So they're definitely one of our more food insecure counties in the entire state. And you know, looking at all of this stuff, this is actually a measure in our regional health improvement plan. And we're hoping to decrease this rate from 13.8 down to 11.3. It's still pretty high, but that would mean a lot less people would be food insecure in Jefferson County. And we have not met this yet, which is why it's showing a big X. All right. In La Pine, what is the availability of behavioral health providers? Our COHC staff have this memorized, so that's why they couldn't play. Getting close, Tammy, not quite. Good guess though. Close, you're really close, Megan. You've sandwiched the number. That's how close you are. All right. Oh my goodness. Everyone's close. I'm going to give you the answer. So the answer is 0.16. Let me share my screen. So this data comes from the Oregon Office of Rural Health. And we track this every year for the rural communities in Central Oregon that have data associated with it. And so those are La Pine, Warm Springs, Prineville, Madras, Redmond, and Sisters. And so La Pine comes in at the absolute lowest number of behavioral health providers for people living in that area. at 0.13. And that is per, let me make sure I'm getting this right. I believe it's per 1,000. So this measurement period is a 3-year. And again, that's to make sure that the data is more stable. This is also a target within our regional health improvement plan. We want to see this increase to 0.62, and we actually have some funded initiatives moving forward around this. Window with the win. Yes, she won. Thank you. Perfect. Okay, next question. Let me make sure I'm getting these. Okay, I have 2 more questions. Actually, I lied, I have 3. They're also important. So have we met our RIP target in any county for hospitalizations due to diabetes? This is a measure in our health improvement plan. See you later, Aman. Thank you. Bye-bye, Rick. Brad, you win again. My goodness. You're too good at this. I'm gonna have to exclude you next time. Okay. So this is the rate of persons hospitalized for diabetes per 100,000. And the way that we can tell that we haven't met these, we can do it a number of different ways. We can choose each county here, and it will open it up and tell us whether or not we've met this target. Because right now it's 95.1 in Crook, and we want to see it decrease down to 86. Another way to look at this is to click on one of these. So the Jefferson target would be to decrease it to 128.8, but we're still at 132.5 persons hospitalized for diabetes. So we have not met this target for any of our counties at this point. Okay, 2 more questions. What county has the highest all cancer incidence rate in our region? Megan, yes. Boy, you must have just known that. So yes, it's Crook County. Definitely not something to be super excited about, but let me pull this up. So Crook County, all cancer incidence rate, this can be found under search for data, and we could do a keyword search just like cancer, for example, and we could find one of this as well as many other measures on the site. But Crook County has the highest all cancer incidence rate with just over 511 people per 100,000. And again, you can look at this data. The source is the National Cancer Institute. And the nice thing about looking at these pages is it shows all the related indicators or measures on our site, promising practices pertaining to this measure, different implementation strategies, and featured pages that may highlight a similar topic. All right, one last question. Where would someone go to see currently funded projects from the 2020 to 2024 Regional Health Improvement Plan? community project tab. Oh, Leslie's even got a link. Let me see if it's accurate. Oh my goodness. Yes, you two are winners. So everyone click on Leslie's link there. And so this is a new section on our site. We're working to build this out, but if people go to the homepage and they click on community projects, this What We're Learning tab are projects that we funded from the past regional health improvement plan. And so it's the outcomes that were shared and all the different learnings that came from each of those funded projects. We're now starting to build out the currently funded projects section, and we're working pretty hard. We haven't caught up yet, but each of these sections will share details about a project that one of the work groups have funded to improve a measure in the health improvement plan. It'll talk about which work group or priority area it is, which future state measure, and if we have a way to track it, this will be linked on our site. It'll talk about who's involved in it, and it can tell a little bit more about why we're trying to improve these measures in our region, what this project hopes to accomplish, an overall description of the project, how this project works and strives to address equity, and the objectives and reporting timeline. So in the future, as we proceed, every single funded initiative will be on this page, and you can see how much it's been funded for, what the timeline is, and what measures they're striving to improve. Kristen says it's her favorite page to visit, and Leslie uses it a lot. No wonder why you two were familiar with it. Perfect. Any questions? Thank you so much for helping me go through that. I appreciate your support. Tammy, turning it back to you.
That was so great, Rebecca. Thank you. And I love the little sort of spicy competitiveness. And I don't know about anyone else. I was like, oh, I don't want to be wrong. That was a wonderful reflection of the usefulness and how readily available that information is. And that just made it really fun. Thank you, Rebecca. Okay, so next we have winner chicken dinner, Brad Porterfield, to chat about the CAC. Would you like, the floor is yours.
Thank you, Tammy. So yeah, the CAC, we just wanted to share that we had a very productive meeting in March with directors of the 3 dental care organizations, Advantage Capital and ODS in our region. And, those kinds of things are always too short because we were just kind of getting going and all of a sudden it's time to be done. But nonetheless, I think we, the staff, helped to really keep us on track and stay focused. And I think there was some learnings that were significant. Some of them kind of make you go, oh, really? And the one that stood out to me was that regular dentists can do periodontal care. You don't have to go to a periodontist, apparently. This was shared by one of the directors. I forget which one. But because that's a huge, our focus was on periodontal care and some issues that have come up with some of our consumers accessing that care, and the dearth of periodontists. There's only 35 in all of Oregon. And I think it's 1 in our region, if I'm not mistaken, if there's even one. Actually, no, there isn't one, because our folks have had to travel over to Eugene and other places. But one of the directors said that you don't have to be a periodontist to provide periodontic care. So that was a pretty big aha for me, and I think for the rest of the folks on the CAC that were there. How that translates to actually accessing that care with regular dentists, I don't know. So I think that's one of the follow-up questions where we're like, okay, so if that's true, then why are we focused on the fact that we don't have periodontists? At least in the short term, why not focus on regular dentists providing that care? And so we never quite got there, at least not that I remember. But that's the kind of thing where like these information, really useful information was being shared by the people that are providing this service and the consumers as well. And yet, so the next step is based on all the good stuff that was shared, we'll continue the conversation. We don't know what that looks like yet, but we're going to continue the conversation and try to kind of piece some of these things together to increase access and increase care. So great time had by all.
Wonderful. It sounds like a good learning opportunity. It looks like Gary would like to comment on what you've brought forward. Gary, go ahead.
Yeah, since it's a dental subject, I always have to comment. But first, I told you in advance I wasn't going to be able to be there personally because I was on vacation, but I got a good debrief from our folks that were there. Just to clarify a little bit on the periodontal care, you don't need a periodontist to cover or to provide the services that are covered under the benefit plan. I don't want to diminish the value of periodontists, that we or general dentists can necessarily step in and do everything that they could do, but it is a very limited benefit plan. And I think that's one of the things, Brad, that was discussed at the meeting was, and also there was some follow-ons. Well, how do we expand the benefit? And I don't know if there was, I think that's one of the things that could be explored further. But from our team that participated and from other organizations that participated, they certainly would agree it was a very beneficial dialogue and would like to keep the discussion going.
Fantastic. Thanks, Gary.
Excellent. So Brad, do you have more to bring forward?
Not really. I guess I'll just follow up on what Gary just shared, though. We did learn that the Health Evidence Review Commission is the HERC, is the body that decides benefits coverage. So that's, those are the kind of pieces where if consumers don't know this stuff, right? We don't know the system. And, through this process, we're learning the system, but it's just, the small number of us that are on the CAC. So then the question becomes, how do we expand this so that more consumers actually understand the system? And so those are our next steps.
Excellent. Linda, dive in.
I just wanted to take a moment to step back from the meeting that Brad just described. There was a lot of staff support and work with the CAC committee itself to prepare us to have what for me was a first time real face-to-face meaningful dialogue with a number of practitioners directly around a specific issue. And I think the staff deserves huge acknowledgement for CAC, for their preparation of CAC and for the thoughtfulness that the process was designed. Secondly, I'm seeing a real tangible shift for me in the level of self-confidence and advocacy that more than one or two CAC members are demonstrating and displaying. I had the privilege this week of sitting in on a small task force with CAC to review our CBI application process. And at some point, I'm sure staff may have felt like, oh my gosh, we've unleashed a monster. But for me, it is so amazing and so rewarding to see a group of people be effective at advocacy and impassioned and believe that they can make a difference. And that's new for me in 5 years here.
That is great. And thank you for calling out the staff. This team is remarkable, and it's really great to see that synergy of making sure that everyone has what they need and is sharing their talents to make sure that, we're just showing up at a place where we feel like we can, be effective. And so thank you for saying that. And thank you, Brad. And thank you to the providers that were making time to actually be there and be open. It wasn't that long ago that it might have not been that welcome of a table to sit at and chat. So it's pretty great to see that growth happen. Okay, so next we have our executive director update.
Hello, everybody. Well, as we come to a close, I just wanted to mention that this is my last board meeting as your executive director. The next meeting that we're going to be having in May, if I can get that projected, is going to be, like Tammy had mentioned before, it's going to be a welcome for Carmen, but it's also going to be an addition to the chapter of the combined meeting for our board and our CAC. And I really do believe that this work that the board and the CAC have been doing together is showing this fruit. I really feel like that coming together that you all decided to do in September, and we promised to do that every 4 months for you, is making a much more cohesive machine. I think there's a lot of growth that's happening and it's going to continue to happen. So in May, I don't see the flyer projected. Could I get the flyer projected? I'm going to be, the big news is that we're going to be in person, and we're going to be in person now for the rest of the year because COVID is not coming back. So in May, we'll be at our East Side Community Room location, which we share with LCA. We will be doing, thank you very much. We're going to be doing a combination of a welcoming for Carmen, as well as doing some work around combined meeting between the CAC and the board. So look for more information about this. This flyer will be going out this afternoon to the board. A save the date went to the CAC earlier today. So there'll be food. We get to do food again, and we will definitely be ready because we're going to have a fun time. And in addition to that, I just wanted to mention, kind of to tee you up for June, we'll be at in Redmond at the High Desert ESD. July, of course, will be dark as usual. And then August, it looks like we're going to be in La Pine. I am pretty sure there won't be any snow in August in La Pine, but today we had snow. So, you know, it's just hard to say. So, yeah, that's all I have, Tammy.
Excellent. And so quick business question. So as we transition to being in person, will we also remain with the ability for remote as well? So we will have virtual as well. Okay, very good.
Thank you. Thank you for reminding me. Yes, we will have a Zoom option.
Okay, wonderful. And as we embark on this journey of transitioning from your leadership, I just want to make sure that you know that we are holding you in that space of being able to carry us through. And we are welcoming Carmen, but really want to make sure that we celebrate you as we go through these next few weeks too. So we will be having a shindig for Donna that will be happening in June. And so can we call out the date? Is that, it's not a secret by any stretch, is it? Okay, good. Camille, do you mind if we call out the dates? We're having it on the same. We cannot. You don't want me to. Oh, you do? Okay, good.
I don't mind.
I don't know. I'm the person that gives away what the gift is before someone unwraps it. So you gotta, so it is June, I think it's June. I have it right in front of me here. Let me June 10th. So yes, June 10th. No, June 4th. June 3rd. Okay, great. How does the 3rd sound? All right, thank you. I know, I'm just trying to get Leslie to laugh. I want to see if we can. Okay, so obviously I'm not a winner today in terms of our prizes, but June 3rd, we have our luncheon also with our work group partners and friends. And then in that afternoon and into evening, we will have a celebration for Donna and her great work as well. So they're sort of backing into that, but just want to make sure, Donna, that you know how much we appreciate you and your help as we go through this transition too. So more to come there. Thank you so much. And with that, unless anybody has anything, we will adjourn. Okay. All right.
Thanks, everyone.
Yes. Great meeting. Thank you.